afternoon, and welcome to the 2012 Schofield lecture featuring Dr. Joe Mayhew, who has come all the way to us from New Zealand, where since 2006 he is on faculty at Massey University, Palmerston North, New Zealand. His present title and positions are Professor in Equine Studies and Head of Massey Equine Institute of Veterinary, Animal, and Biomedical Sciences. New Zealand is also Dr. Mayhew's country of origin, and his present position at Massey comes after a long and distinguished career in veterinary neurology at many academic institutions on the other side of the world. After acquiring his BVSc from Massey in 1967, he was in mixed practice in New Zealand and for a while in Australia before he made his way to North America. And this is where I first met Joe Mayhew. He came as an intern in large animal medicine and surgery at OVC. I, at the time, was new faculty and an embryonic neurologist, all excited and inspired in the specialty of neurology because of my association with and learning and study leave at Cornell with Dr. Alexander Delahunty a few years previously. The main thing I remember about Joe from that time was his very inquiring mind. I still have a vision of standing over a calf in Ward 3 and Joe striding toward me to find out the results of my neural consultation on this calf. I thought, better have this evaluation right because Joe is going to want every detail and to see it for himself. I am most honored by Joe acknowledging that I actually contributed to his decision to pursue a career as a veterinary neurologist. From OVC, he did a residency in California and then became a PhD student with our mentor extraordinaire, Dr. Sandy Delahunty, in 1974. Here he did a magnificent treatise on my favorite subject, by the way, on many clinical cases of equine ataxia, which was complete with clinical data, gross necropsy, statistics, and histopathologic examination. From 1997 to 1988, he was a professor in the College of Veterinary Medicine at the University of Florida, in addition to being chief of the Large Animal Medicine Service. In 1984, he was also appointed professor in the Department of Medical Sciences and Department of Experimental and Comparative Pathology at the University of Florida. I'm sure this period of his career cemented his expertise in large animal neurology and led to the first edition of his Handbook for Veterinary Clinicians in Large Animal Neurology, published in 1989. An enhanced hardback second edition arrived on bookshelves in 2009. In 1988, Dr. Mayhew moved on to Britain and became head of the Department of Clinical Studies at the Animal Health Trust, Newmarket, England. From 1992 to 94, he was also an associate lecturer at the Vet School in Cambridge. From 1994 to 2006, his place of academia, director of the Large Animal Hospital, and head of Division of Veterinary Clinical Studies was the Royal Dick School of Veterinary Studies in Edinburgh, Scotland. Although Joe is renowned as a large animal clinical neurologist, he has been a major investigator in research projects, both veterinary and comparative, that go to neurophysiologic, biochemical, and ultra-microscopic levels. This has resulted in many scholarly papers over the years, over 200 and still counting. Dr. Joe is a diplomat of the American European College of Internal Medicine and Neurology, a fellow of the Royal College of Veterinary Surgeons, and in 2006 he was inducted into the Equine Research Hall of Fame at the University of Kentucky. He was also granted a special Doctor of Science degree from Massey University that is based on an external review of the extent and depth of his scholarly activities throughout his career. As might be expected, Dr. Mayhew is a very popular speaker and has been invited to give presentations all over the world. His latest focus has been South America, and he was a little surprised to find out, while en route from New Zealand, that he was flying over the Antarctic, which is apparently the shortest way to South America. And now I am so pleased and excited to present Dr. Joe Mayhew to speak to you about my most favorite subject, and certainly in agreement that veterinary neurology is fun.
Thank you, Laura. Well, thank you so much, Laura. It's a real honour to come back to Guelph, which undoubtedly did spark my interest in, I wouldn't say just in large animal neurology, in neurology in general, and in medicine, and in veterinary science. And it was people like Laura and Prof. Willoughby, who I was pleased to see here, who helped answer some of my questions, because I do tend to ask a lot of questions of myself as well, which is probably useful. It's a real honor to be part of this celebration that you've been experiencing today, and to have it named by, given the name of the Schofield lecture, makes me very humble. He was obviously a gentleman and a profound social worker, as well as a veterinary scientist. And to achieve what he did was quite remarkable. I found this image of Dr. Schofield on the website, and I realized that he was riding a donkey, but I hadn't realized at that stage that he had been struck by polio and had a gammy leg, which he almost totally ignored for the rest of his life, but didn't stop him doing anything, which I think is a good little moral from his life tales. It certainly has been an honor, and in case I forget to say at the end, I'd like to thank everyone that organized this whole program. I've been thrilled to have a look around your wonderful school that I've kept a strong interest in. The veterinary profession's very small, and so we tend to know each other. And you're all welcome if you happen to make it down to New Zealand. Not all at once. I really am a large animal clinician, and that's what I enjoy the most. It's what I spend most time doing, working in the clinics with students. And the students have replaced my mentors like Professor Willoughby and Laura and many others, Sandy Delahunter, because they keep asking the questions, and you've got to ask those same questions yourself. And I do enjoy working with all species, not just horses. I've just put a few cartoons up here, but I mean, pigs are fantastic animals with all their neurologic diseases and their wonderful larynges when you're doing the exams that you have to respect, and the donkeys with their pretty accurate hind legs and all the rest of them. So, but I will use mostly some examples from equine neurology to try and share some of the fun that I've got out of this area of interest. And I do have to pay respects to all of the patients that have actually taught me all the neurology that I know, because in the end, that's, I think, where we learn our clinical skills, is from the animals. So I've suggested that we could think through some of the things I've enjoyed asking these questions as we go. And it sounds a bit hackneyed to ask these questions, because anyone that picks up a neurology book is always asked, well, where's the lesion and what's the cause and why does it happen? And it sounds a bit mundane, but it's very useful to keep asking these questions. And even when we think we've got the answer, it's worth asking the same question again, because we fool ourselves. We think we know the answers to these questions. And that's the excitement. It's a bit like playing detective. The only question mark not there is who did it. But otherwise, it's that sort of excitement that I get out of looking at clinical cases. There are several diseases that have perhaps taught us more about neuroanatomy, neurophysiology, and diagnosis. And like listeriosis in ruminants would come to mind, distemper in small animals, for those of us old enough to have seen a few cases. And this disease, which is quite astounding, and as Laura suggested, while we were in Florida, we saw lots and lots of this disease, and it really was experiments in nature. You couldn't have done these experiments better if you tried. So to create a lesion like this, where you have caused inflammatory necrosis of the motor nucleus, of the trigeminal nucleus, nothing else in the nervous tissue, that's pretty impressive. And then to create a lesion in part of that nucleus with different clinical signs. So that was the sort of thing that really turned me on to the integrating clinical studies with the pathological processes. And I think integrating them is very important. So that same disease taught us that, yes, if you cause a lesion just in the hypoglossal nucleus on one side, you get atrophy of the tongue, nothing else, which is quite impressive for a disease process. The same with the horse on the left there, where it's in its praying posture because of profound bilateral weakness in the thoracic limbs and no signs in the pelvic limbs, which is quite amazing for a central nervous system disease process. And the last one is just ephemeral paralysis. So many of these look like they're peripheral nerve diseases. Very, very selective, exquisitely selective, but they teach us the whole pathways. So I could go on and use lots of examples from that disease, because it really has taught us a lot as to where is the lesion going by the clinical signs. And so after dissecting lots of brains and spinal cords, etc., one can teach oneself a bit of neuroanatomy, and you think you understand the pathways. And I thought at one stage I understood the vestibular system reasonably well. There's an ear, and then there's an inner ear, and that sort of feeds the vestibular nuclei in the brainstem, and it has pathways to most of the muscles in the body, especially extensor muscles, and maintains tone in all those muscles. And that seems to be pretty useful, because God made gravity, and we had to have something to fight against gravity. And this system seems to do a good job. And I thought, well, that seems to be straightforward. Well, this horse arrived, and you can read the history. It was a very obliging mare who had sustained an accident. I won't go into the details, and received a very minimum dose of a drug to relieve inflammation, but just one dose. And those were the clinical signs. It was pretty obvious the horse had sustained a neck injury with a swelling on the side of the neck and reluctance to move, and you moved the head and created crepitus, so you didn't move it again in case it fell off. So we're all quite smart, and we knew what was going on here. The horse has got a spinal cord injury because it was very, very ataxic. But I'll come back to some of those clinical signs. After a little while, we thought it was reasonable to radiograph the neck, and yes, sure enough, there's evidence of trauma. You can see a fragment off the front of the spine of C2. and all was hunky-dory. We didn't do very much except watch the horse, and this is the horse. If you follow the dates, you'll probably follow how long it is. I think this is 3 days after the injury, and the horse has pretty profound ataxia. In fact, it was on its way to radiology to take those Ryegrass you just saw. And we were very cautious because we knew it had a very sore neck and a broken neck. So that's the horse. I believe it was 3 days after the injury. And there's another sequence now. Do we need the lights down? Do you think we should put the lights down?
No, it's quite visible.
Okay. Here's the horse. I think it's now 10 days afterwards, if I recall. Quite improved, but not normal, of course. So that was all very straightforward. It seemed that she was a wobbler and had ataxia and weakness. She was pregnant at the time. She did lose the foal, which probably wasn't related to the injury, but maybe. And this is 3 months later, just with box rest. And at this stage, it's difficult to convince everybody or anybody that it's got neurologic signs. She subsequently went on and became a riding mare again, and subsequently was rebred again. And it all seemed hunky-dory. Well, after about the 100th time of looking at that video and thinking about the case with those clinical signs, I was a bit perplexed because there really wasn't a lot of evidence of weakness. And it had profound lesions relative to the cranial cervical region. You can now see what's developed, which is total muscle atrophy over the atlas and axis, and an analgesic saddle at that level, analgesia, not just decreased sensation, and still this piece of displaced spine of C2. And the fact the mare recovered rapidly and completely from a pretty profound neurologic disease. And it also bothered me that the ataxia had characteristics of vestibular ataxia, not spinal ataxia. And if one thinks about it, it's incredibly difficult to explain this whole syndrome with just spinal cord compression. In fact, I think it's probably impossible. Maybe with a vascular accident associated with it, but it's very difficult. And so what we went on to do because of this, after talking with some colleagues in Denmark and looking up at the old physiology literature where they did nasty things to primates and cats and things, we realized that missing in a lot of our clinical neurology texts, human as well, was this spino-vestibular tract, not vestibulospinal, spino-vestibular. So pathways coming from the spinal cord, particularly the neck, to the vestibular region. And we were asking ourselves what this tract does. So Charlotte Ryegrass, a colleague from Denmark, after we were discussing this in quite a bit of detail, had gone ahead and done some experiments by putting local anesthesia in the cervical nerves of ponies. And I've just summarized, she did a lot of these, and without boring you, I think there's good proof that none of the local anesthetic went into the epidural space, and it was just involving the dorsal spinal roots of C1, C2, C3. And this is the sort of clinical syndrome that appeared. No spinal cord involvement, just anesthesia of the C1 dorsal nerve roots. The C2 nerve root. And 2 nerve roots. And there was appropriate total recovery in the time you'd expect the local anesthetic to wear off. And there's no weakness. It's just vestibular ataxia. So that pathway is almost certainly a fairly important pathway. We believe in animals that have long necks. It is present in humans, and in primates you can see similar clinical signs with sectioning of those that has been done in the past. So we believe the better explanation of the clinical syndrome is that there was severance of at least the C1 and possibly C2 nerve roots, not the spinal cord, no damage to the spinal cord, causing this saddle of analgesia, and the ventral nerve roots to cause local muscle atrophy. And the clinical signs were predominantly because of vestibular ataxia. So again, we re-asked ourselves, where was the lesion? But because I'm so slow at taking things on, I had to look at this video about 10 or 100, I don't remember how many times, before it cottoned on to me that something was not explicable. So I will just turn quickly to another part of the nervous system which has intrigued me somewhat. That's the autonomic nervous system. And all clinicians will recognize that those eyes belong to a horse that's got Horner's syndrome. And so there's a lesion somewhere in the sympathetic supply to the eyeball on one side. Dr. Horner, who was a Swiss ophthalmologist, described this, and it's reasonable and very acceptable that you can have a lesion anywhere along the pathway from the brainstem down to the cranial cervical spinal cord and anywhere back up the neck in the cervical sympathetic trunk that parallels the vagus nerve and produce these signs. You get a nice variation, and we'll come back a little bit to the different sweating aspects, but the ophthalmic signs fitted the picture. And one thing we did learn was that in horses and cattle at least, that this cranial cervical ganglion doesn't reside close to or in the bone surrounding the inner ear cavity, the petrosal temporal bone. But we asked ourselves, why was the common finding ptosis in these animals? And the explanation should have been very obvious, but we decided to look at this because if you look at the presence of ptosis suggests that you can't raise the lids. So we're interested in what muscles raise the eyelids. And I've just listed those there and de-emphasized the third cranial nerve because we really still don't know too much about that nerve in horses, at least I don't. We know that the levator palpebrae superioris is present, but I'm still a little unsure as to its innervation, its total innervation. The muscle that receives all the attention is this levator anguli oculi medialis, or the medial angular muscle. So it's the muscle that creates this angle in the equine eyelid, and it's very, very prominent for their facial expression. So it pulls the corner of the eyelid up onto this angle. Instead of it being an arch, it's almost a right angle in some horses, and it gives them the part of their facial expression. So in seventh cranial nerve disease, you lose that and the eyelid droops. And Muller's muscle, or so suppose it should be called the superior tarsal smooth muscles, so theoretically should explain the ptosis or drooping that you see in sympathetic disease or Horner's syndrome. But with that damaged, one shouldn't see a change in the angle of the corner of the upper eyelid because the facial nerve should be intact. This is fairly important because in clinical practice, many of us do get confused with the droopy eyelid that is seen with facial paralysis and Horner's syndrome, because the eye signs in Horner's syndrome in horses can be fairly subtle if it's a partial lesion. In doing this, we realized that there was another group of muscles innervated by the sympathetic supply to the periorbit, and that's these arrectoris ciliorum muscles. There's a whole lot of them. And they're responsible for elevating the eyelashes on the eyelids, which I'm sure a lot of ladies in the audience would wish they had. It doesn't seem to be present in all species, but they are quite prominent muscles in the horse. And when we went back and looked at 20 or so pairs of photographs of horses with Horner's syndrome, we realized probably the most prominent sign that's present is droopy eyelashes, not a droopy eyelid. Now, one has to have a control side because some horses look through their eyelashes just like some people do, and some have them sticking up to the moon. But it is a very prominent part of Horner's syndrome, and you wouldn't expect it and don't see it with, say, facial paralysis producing ptosis. So we added that to the trilogy of signs that's seen with Horner's syndrome as these drooped eyelashes. We were fortunate, and unfortunate, I suppose, to see lots of horses in Scotland that had this dreaded disease referred to as equine grass sickness or equine dysautonomia, where there is a partial or possibly even complete destruction of the peripheral and some of the central autonomic nervous system in these horses. So, of course, if it's a severe lesion, that's incompatible with life. But many of these poor horses would survive for quite a while with bilaterally symmetrical autonomic nervous system signs involving all parts of the body, including the eyes, and therefore Horner's syndrome. So they'd come in with bilateral Horner's syndrome, and it was difficult to tell that they had ptosis because they were sick, they were dehydrated, they'd lost 150 kilograms in a week. So they were poor specimens, and droopy eyelids didn't really tell you very much. But the droopy eyelashes were what were very, very prominent. And because of the prominence we saw with this in Horner's syndrome and in grass sickness, we thought that that might be a useful indicator in using some topical challenges, as is done with Horner's syndrome diagnosis in other species that we had totally failed at being able to use in the horse, and that is using agonists and antagonists for the autonomic neurotransmitters to see what the response is in the individual patient. And we'd failed completely. But this was such a prominent sign, we thought it was worth persevering with. So with a lot of trial and error, we found that using a selective alpha-1 agonist, agonist, an adrenergic agent agonist, in these cases, you could very quickly reverse the eyelash angle change and very quickly convert a grass sickness horse into this, from this to this, within about 5 to 20 minutes, depending on the severity of it, which was very helpful to confirm that that's further evidence that the horse has bilateral Horner's syndrome, or bilateral loss of sympathetic tone to the eyelashes. And that test, using a low concentration and a small amount of this replacement agonist neurotransmitter, was a useful way of helping to diagnose this very horrible disease, grass sickness, because if the diagnosis was secure, then the only option was euthanasia, and the sooner the better. I mentioned the sweating, and many of you that have looked at lots of horses will realize that if you take the sympathetic supply away from the skin of a horse, the area sweats if it's got lots of sweat glands. And so we would see variations, association with Horner syndrome, with periorbital sweating, or sweating down to the angle of the jaw, or C1, the cranial cervical region, or sweating down to the level of C2, 3, or sweating all the way down to the neck in conjunction with Horner syndrome. And this was very, very useful as another mark as where the lesion is. In the first case, that's a retrobulbar lesion, so there's only damage to the sympathetic supply to the eyeball and the periorbital skin. Whereas if there's a lesion in the guttural pouch, a common site for various diseases in horses, that would be a lesion at the site 2, you'll have sweating down to about cranial C1, or the just to the back of the jaw. And if you have one at C3, then you get sweating down to C2, 3. But that doesn't make sense, because the books tell us that the supply to the sweat glands of the head all come from the cranial cervical ganglion. Well, some horses, or most horses actually, didn't read the book, and they don't do that, because if you look in the cervical sympathetic trunk, you'll find cell bodies of third-order neurons, sympathetic neurons, prior to the development or accumulation of most of them in the cranial cervical ganglion. So many of them separate from this trunk and go out and innervate that region between there and there. So that can help distinguish between a lesion which is affecting the postganglionics versus those that are affecting these extra cell bodies, the third order neurons, that's what I meant, that have left the cervical sympathetic trunk before it reaches the cranial cervical ganglion. And if one has a lesion that is down at the origin of the cervical sympathetic trunk after it's left the thorax, the cranial thorax, one can get sweating on the head and at C2, 3 and all the way down the neck. And that's because, which is follows the textbooks quite reasonably, that there are the branches that are innervating the neck don't travel up the cervical sympathetic trunk, but they leave and join the vertebral artery as the paravertebral nerve, and they travel up parallel to the the cervical sympathetic trunk, and give off branches segmentally with each cervical nerve to the blood vessels on the side of the neck. So again, you can use this to define the anatomic site of a lesion. And incidentally, if there is a sympathetic denervation or decentralization for a long time, sweating turns into anhidrosis, probably because of overstimulation and then final atrophy of those sweat glands. So there's a horse over a period of about 3 years with sweating in that region and then a dry patch in that same region. Another way we can tell that. The final one, and I had to put this lovely picture of Laura and myself's mentor, and probably the mentor of many people in the audience, Sandy Delahunter, but he doesn't like me putting this up because it is the arse end of a horse. But he'll forgive me perhaps. I don't have many pictures of Dr. Delahunter, but that's one of them. The final situation is where there's sweating over the whole side of the body. So there's Horner's syndrome, and there's sweating over the whole of the neck, and there's sweating over the whole of the trunk. And the only place that you can have that lesion is in the descending descending tectotegmentospinal pathways, or the preganglionic pathways, from the brainstem down to the sympathetic outflow in the thoracolumbar region. So sweating over the whole side of the body. What intrigues me, I'm afraid I always have to ask why again, what intrigues me is that you have actually denervated the adrenal gland on one side by doing that. And that doesn't seem to be a very healthy situation, but the only 2 horses I've seen it in haven't had overt evidence of autonomic failure in any other way, but it raises a lot of questions. So we're still asking, where is the lesion? And I'll switch a little bit to another peripheral nerve disease, so-called Stringhalt. Although I prefer this last term, and I'm hopeless at German, but Hanentritt, I think I should say, or rooster kick. And I think this picture sort of demonstrates the rooster kick a little better than the horses do, but it's a far better name than Stringhalt. I'm not sure where it came from, even though I should. And we've asked for a long time what's the cause of bilateral Stringhalt, I'll talk about here. It's a very common disease in some parts of the world, including New Zealand, where pastures do get dry in the summertime. And this is just a demonstration of the very unusual syndrome, which all equine practitioners are very familiar with. Very spectacular and very debilitating. And that's where it got its name from. And for many years, workers much cleverer than myself have worked out that there ultimately is a degree of neurogenic atrophy in the distal muscles of the pelvic limbs. And so we can demonstrate in these cases that you've got peroneal nerve disease, you've got muscle atrophy, at least in lateral digital extensor, and ultimately in many other muscles. And so that suggests that you've got a factor, presumably a toxic factor, acting on multiple peripheral nerves, producing this neuropathy and producing muscle atrophy, and with accompanying EMG changes to go along with that. But that really doesn't help us explain an unusual movement. If you've got paralysis of muscles, the usual thing is you can't use those muscles. So it begs the question of whether indeed that insult, a presumed toxin, actually damages some of the smaller fibers, the sensory fibers, or their target structures, such as the neuromuscular spindle and its own intrafusal muscle fibers. So if you damage these 1A afferents or you damage the muscle spindles, you can change those whole reflexes so the muscle doesn't work at the right time before it gets atrophied because of the effect of the same, presumably, factor on these alpha motor neurons, or the ones innervating those said muscles. So it may be that that's the mechanism of the disease, that it's a selective peripheral neuropathy originating in either the gamma efferents or 1A afferents or muscle spindles, and then spreading to involve the alpha motor neurons and ultimately muscle atrophy. And indeed, this can occur in other parts of the body. These same lesions we can detect in the thoracic limbs, where the signs are very, very different, because the thoracic limbs, as all our anatomy teachers told us, don't have the reciprocal apparatus that the pelvic limbs do in horses, and to a lesser degree in other species. So when we have a muscle contraction at the wrong time, the thoracic limbs usually extend, whereas the pelvic limbs usually flex. So we're all very smart and think we can explain these unusual disorders by a peripheral neuropathy. But what's the cause of the problem? Well, for many years, lots of other people have put together large numbers of cases in various countries, and I might emphasize not just Australia, for those of you in the know, many countries throughout the world where bilateral Stringhalt is a huge problem, New Zealand being one of those countries. And it's often associated with one of these three plants, most commonly cat's ear or false dandelion. It's not dandelion, false dandelion. And for those that might be interested, the simple difference is that the dandelion flower is on one stem, whereas the false dandelion or cat's ear is on a branched stem. That's my simple way of distinguishing these yellow flowers that you see in New Zealand from now on, from springtime onwards. And it also involves older and taller horses, which I think is quite intriguing. A colleague in Brazil has managed, finally, to probably induce the disease in one horse. You can see that's quite a mouthful of false dandelion to eat. That's quite a lot. And there's a few other aspects to the disease situation. It was only one animal, but it's the closest anyone's come to reproducing this disease, I believe. And lots of people have tried, with lots of horrible yellow and green plants being fed to horses. So we didn't want to start feeding horses with lots and lots of this stuff. It takes a long time with a scythe and a wheelbarrow to pick that amount of stuff, so we're a bit lazy. But we did manage to have a group together, which was sort of the catalyst for this was Rob Mackay, who's a colleague of ours, coming from Florida for a sabbatic for a year, and he headed up this little group that we had an interest in. And we wanted to look at the in vitro effects of extracts from this plant, and so we collected aerial components of the plant at the time of year when it is not heat stressed, which seems to be when the disease occurs. And we used a classical neurotoxin, which many of you will be familiar with, and looked at it with Chris Thompson's techniques of organ and cell culture, and those are some of the tissues that we used. And just to quickly go through what was found, so this is spinal ganglia explants, and with a negative control in the top left, and the repin at that concentration in the top right, which has done a nasty job on those neurons. And then the stressed and unstressed extracts as applied to these spinal ganglia explants, you can see the effect, which seems to be a dose effect in damaging those compared to the controls, and in parallel to the effects of repin. And looking at it another way, looking at the vehicle and the positive control repin, and then unstressed and stressed, and using the microscopy to show myelin versus axons, one can see that, again, there seems to be an effect of these stressed extracts from the plant in damaging those cells and their peripheral axons. That doesn't really tell you very much because it could damage any cells. And one of my other mentors, Bill Blakemore in Cambridge, or was in Cambridge, I know what his first comment to this would be. He says, well, you may as well spit on them because that will do the same thing. And he's right. He's absolutely right, the dear cynic that he is. So we should see what the effect is on fibroblasts. And the only reason of putting these into the equation is that repin is known to be relatively selective for neurons versus other cells, but we wanted to look at these and measuring the cytotoxicity of the cell bodies using LDH markers as to lethality or not. Excuse me. And this is just comparing the cytotoxicity at different concentrations, and again there does seem to be a dose effect. Now, it hasn't really proven anything, but it does open up the prospects of looking at those extracts, which we're in the process of doing, as to whether there are components of the extract and whether or not at lower concentrations they can produce these earlier changes rather than total killing of the cells, before we go into other mouse models which start to get a bit more invasive. So it's another step along the way as to why the lesion is occurring, but we haven't got there yet. We're asking the same question as to where the lesion is. We were fortunate and unfortunate, because of the horses, to be involved with several outbreaks of a syndrome like this in Scandinavia and subsequently elsewhere, where the horses would show evidence of a peripheral neuropathy, and they would show degrees of ataxia and degrees of motor paralysis, which was very consistent with sciatic nerve involvement. So in this case, very much peroneal involvement, so there was knuckling over. And some of these horses would be so bad they'd be recumbent because they couldn't rise. Others would tend to show almost entirely peroneal nerve involvement. Pretty devastating sort of disease process, and it tended to occur in the winter and spring when lots of dried feed or stored feed was being used. So again, a peripheral neuropathy, which I'll show you, several people have managed to show there is similar damage to those peripheral nerves. Subtle signs, but once you see the clinical syndrome, it's very typical of a partial peroneal paresis. And there have been and probably still are many outbreaks of this, which is again very devastating, and large numbers of horses affected over a period of time, not all at the same time. And some of them will improve, but not usually totally recover, which is fairly typical for the long nerves we have affected in horses with any neuropathy. Some of them had evidence of femoral nerve involvement. There doesn't appear to be involvement of the autonomic nervous system, nor of other long nerves perhaps. That's still to be decided. So no clinical evidence of laryngeal paralysis. They certainly have evidence of Wallerian type degeneration in peripheral nerves, and of course there's a big search on for these putative toxins. And the reason that this has become rather topical for me right now is because of a syndrome in New Zealand which has reared up in the last 2 years, which, for lack of anything else, we've called sciatic palsy. I just thought I'd throw in an old-fashioned term there, because I don't know what it's caused by. And these knuckling cows, which show exactly the same syndrome, the same peripheral nerve disease. And indeed, some of the Scandinavian practitioners did tell me about 10 years ago that cattle on the premises could also be affected. We initially thought that these animals were the typical, which I'm sure many of you are aware of, this crushed tail head syndrome, but these cows have no CT evidence of crushed tail head, no pathological evidence of it, just a neuropathy involving the peripheral nerves. So a big question mark in our minds, but something that I should have realized. We should have looked closer at these horses in Scandinavia. So far, I don't believe anyone's answered the question as to why this happens, or what is the cause of the lesion. Can I switch to also another very common disease in the southern hemisphere? Wherever perennial ryegrass is grown and fed to horses, but also in other countries. And that's this intermittent clinical syndrome, which I think is quite incredible. So there's quite a prominent syndrome, and then the signs improve very, very quickly, seconds to minutes. Sometimes they don't. The horses remain with these signs and can become recumbent. But they have degrees of swaying, tremor, ataxia, no weakness, hypermetria sometimes, such as this horse. Wide base stance, and the muscle tremors, when present, are usually also present in the muscles controlling eyeball position. So they have trembling eyeballs, which you usually only see on an ophthalmoscopic exam at the fundus by exaggerating the movements, magnifying the movements. Well, we were interested in what true perennial ryegrass staggers looked like in horses, and we did get permission to look at this in horses specifically. But before we did that, we had to rely on a lot of work by other people on this syndrome, which is a fascinating disease. This perennial ryegrass staggers is an acquired channelopathy, so all excitable cells that have got a BK channel, one of the channels controlling monovalent cations, are affected, but the ones where we see the clinical signs are those in nervous tissue and probably muscle tissue. And the toxin has been reasonably well characterized, one of them being, the toxins, one of them being Lolatrem B, and that's the lovely formula, which looks like anything to me, or nothing to me, I should say. But it does affect the BK channels and therefore alters potassium fluxes across these vital excitable membranes. And we were rather interested in what other clinical signs we may be able to detect in subtle cases, because the early diagnosis is so important to stop the disease progressing. Even though most animals recover, they can take a long time. So we were interested in where else these channels are expressed, and they're expressed in a lot of other tissues. And I won't bore you with all of those. We did try to look at the effect that this might have and the measurable effects. So first of all, this was just a very brief synopsis of the clinical syndrome that we produced with Lolatrem B and some contamination with a few other mycotoxins. We would get these rather unusual muscle tremors, which reminds one of myokymia or writhing or spreading muscle tremors. Like that there, which many clinicians would call myokymia. And one would see apparent behavioral effects, which is often what the clients complain of, and prominent tremor. And these signs all abated within about 2 weeks of stopping the feeding. And the ataxia worsens with blindfolding, and so that adds to the evidence that it is a vestibulocerebellar ataxia. So we were happy that we could characterize and mimic the clinical syndrome fairly specifically. But we were also interested in some of these other signs. That's just a summary of them that I think I've mentioned most of them. Quite prominently, there being what we thought was no weakness. We didn't believe these animals were clinically weak, but we had decided to look for evidence of occult weakness. And so we did use the motor evoked potentials, which is just to sort of give a little teeny bit of background. So if you create a sudden magnetic field over the motor cortex in a primate, you can initiate impulses traveling down the motor pathways to the muscles and cause muscle contractions. And it's relatively painless, but it's frightening if you do it to yourself. Because it makes a big noise. That's basically what happens. But It doesn't hurt you. It's like putting your hand in front of a magnet. So we would record both the extensor carpi radialis and cranial tibial muscle contractions to these muscles, to the magnetic stimulus. And just so if we have damage to the spinal cord, for example, this is a wobbler which has had that procedure, and we get a delayed and a dispersed muscle contraction as opposed to what we expect in the control animal. So we did these on the Ryegrass staggers that supposedly didn't have any weakness. Now, we didn't have enough animals in which this could be done without any sedation to do statistical analysis, to achieve statistical significance, I should say. But there were 2 horses that had prominent changes before versus during feeding versus after feeding of the lolotrem. And they had delayed magnetic motor conduction velocities, or times. So it brings our neurologic exam into question, that we're pretty hopeless at finding muscle weakness, or there's some error in our technique. So that was another unanswered question, whether or not they actually do have weakness or not. And one of the other things, we did look at several characteristics. One was we were interested in the BK channels that are expressed very much in the renal tubules, and they're associated with responses to pressure. So volume of urine and pressure within the tubules after a dose of furosemide to increase the volume of urine production. So it's a bit of a complex response we're looking for. But we did see quite a difference in this rate of change of fractional excretion following furosemide challenge before and after feeding the lolotrem. And the surprising thing to us was that the sodium changed perhaps as well. So all this convinced us really was that there very likely is changes in other BK channels throughout the body, not just those in the nervous tissue. And of course, if this could be made a little clearer and a little more precise, it might be useful from a diagnostic point of view to see what fractional excretion changes there are early in the course of the disease. So we ended up asking a lot of questions rather than answering why do these signs occur, but it's fun in trying to answer the question. That also led us, we were very fortunate after studying that acquired channelopathy, to this disease, which is a fascinating disease, I think. There are these lovely New Zealand Romneys running around in the paddock, and these are the sort of syndromes they get. And you would think they're having seizures. I actually could have the audio. No, I've missed it. But the lambs are vocalizing quite happily, well, unhappily. And this is the experimental disease when we have rebred the sire and dams, the sires with normal dams. And here's a lamb going into one of these episodes because it was perfectly normal 2 minutes ago. And of course it's having a seizure would be the first thing we say, but it's not having a seizure. It's either drinking very fast-acting Jim Beam or it's got a neurologic disease. And once you get them in the yard and stimulate them a modest amount, lots of them will show signs. But docking doesn't induce the syndrome. See, they're all born with red marks on if they're affected. It's easy to diagnose them that way. So after looking at the clinically, we thought this has to be an episodic ataxia. which is well recognized in some rat models and in humans, and it's devastating in humans. This is now in the older lambs, and they can be perfectly normal and then have even asymmetric vestibular ataxia. And that's just a summary of the clinical syndrome, which is quite impressive to see. I won't go into it too much more because I think the video has shown you what they can do, but just remind oneself that within 5 minutes those lambs can be 100% normal. By 12 weeks, which is what yes, that was 12 weeks, the last little clip you saw, they show minimal signs, some of them no signs. So they seem to grow out of it. By 24 weeks, they're perfectly normal, but one of them has got epilepsy, and that is a side effect, that is a cast-over effect of some of the episodic ataxia syndromes in humans. Just to finish the story of our breeding, we did have reasonable evidence to show that it was a dominant gene with variable penetrance. And we had 2 sires. So we've rebred them this year with a similar result. The interesting thing comes when we ask ourselves, well, what's causing this? And the reasonable assumption is that there's a protein that's got screwed up by its gene. And we've started looking at some of these. We're pretty sure that it isn't the VG channel, either the calcium or potassium associated one. So it doesn't fit the classical EA2, which is the episodic ataxia in humans -2. But clinically, that's the syndrome that this sheep disease looks like. It is an autosomal dominant with partial penetrance and variable expressivity, which is what this syndrome is. So we've embarked on some pharmacological intervention and are still looking for the probes. We think we've got one, but I can't speak any more about it. It's a lovely disease to think about these questions as to, well, if we get the gene, then the geneticists tell us, well, now we know the cause. Well, I don't think so. If we go back to this sort of thing, which makes it very clear, that's just to remind me how unclear disease diagnosis is. We thought it made a lot of sense, didn't it? To start with, we described the syndromes. And Edward Mayhew in 1864 described rabies better than I could. And it was the description of the disease. That was it. That's end of story. Well, and then the geneticists came along and told us that no, most of these diseases are due to these genes. And then the proteomic specialists came along and said, no, it's the protein that's expressed, that's the problem. Well, I'm a little happier by taking it to this next level that many clinicians have, and that's to look at diseasomes, because it's not just one gene that is going to produce most of these. If this was ovine episodic ataxia, we think we've got one gene, but that disease is not going to appear without these environmental influences and probably the effect of lots of other genes. So I like to keep asking why it happens, even if the geneticist says it's got that gene, therefore it's got that disease. I'm still awkward enough to ask them, well, are you really sure that that's always the case? Because I like to keep asking questions. And on that note, I will finish. Thank you.